A blood sugar reading of 92 can be reassuring for one person over 60 and a warning sign for another. A reading of 148 can mean poor control in one situation and an intentionally safe target in another. That sounds contradictory, but it is the reason so many older adults become confused, frightened, or even overtreated. They see one chart at the pharmacy, another number on their glucose meter, and a completely different goal written in their medical record. Then they assume someone must be wrong. Usually, nobody is wrong. They may simply be talking about three different things. There is a number used to diagnose diabetes. There is a target used to manage diabetes. And there is a danger line that tells you when blood sugar may be getting too low. Those numbers are not interchangeable, and mixing them together can lead to exactly the wrong decision. So in the next few minutes, I am going to show you the 3 target patterns doctors commonly use for adults in later life. You will see why a healthy 66-year-old may be given a different goal from a 76-year-old with kidney disease, and why an 84-year-old who needs help with medications may have a different goal again. But stay with me, because there is one number that can expose a problem even when your A1C looks perfect. It can reveal dangerous overnight lows, hidden after-meal spikes, and the blood sugar roller coaster that an average can completely conceal. First, here is the answer most people came for. For an older adult with diabetes who is healthy, independent, and has few major medical problems, a reasonable A1C goal is often below about 7 to 7.5%. A common fasting or before meal target is about 80 to 130 milligrams per deciliter, and a common bedtime range is about 80 to 180. For an older adult with several chronic illnesses, mild memory problems, difficulty managing complex daily tasks, or a greater risk of low blood sugar, the goal is often relaxed. An A1C below about 8% may be reasonable, with fasting or before meal glucose around 90 to 150 and bedtime glucose around 100 to 180. For a medically frail adult, someone with advanced illness, moderate or severe cognitive impairment, major dependence on others, or limited life expectancy, doctors may stop using A1C as the main target. The focus becomes preventing low blood sugar and avoiding high blood sugar that causes symptoms. In that situation, fasting or before meal glucose may be allowed around 100 to 180, with bedtime glucose around 110 to 200. Those are not personal prescriptions. They are general clinical frameworks, and your own target may be different. But they reveal the single most important truth in this entire video. Age alone does not choose your number. Your overall health, medications, thinking and memory, kidney function, daily independence, and risk of hypoglycemia choose the safer range. And here is where people make their first big mistake. They look at the diagnostic chart and assume it is also their daily treatment target. The familiar diagnostic numbers do not simply disappear after age 60. A fasting laboratory glucose below 100 is generally considered normal. A fasting level from 100 to 125 is in the pre-diabetes range. A fasting level of 126 or higher can meet a criterion for diabetes, but in someone without clear symptoms, diagnosis normally requires confirmation with another abnormal test. An A1C below 5.7% is considered normal. 5.7 to 6.4% is in the pre-diabetes range, and 6.5% or higher can indicate diabetes when properly confirmed. Those are diagnostic thresholds. They help determine whether diabetes is present. Think of these as 3 different clocks. The diagnostic clock asks, does this person meet the medical definition of diabetes? The treatment clock asks, what range should we aim for during ordinary life? The safety alarm asks, is this reading low enough or high enough with symptoms that action may be needed now? A number can be important on one clock without carrying the same meaning on another. This is also why copying a friend's medication response can be dangerous. Your friend may take a drug that rarely causes hypoglycemia, while you may use insulin. Your friend may have normal kidney function. While your kidneys clear medicine more slowly, your friend's 110 may be stable. Your 110 may be dropping quickly. A meter displays the current number, but it does not automatically display the direction. The medication still active in your body, or what happened during the previous several hours. The context is not an excuse added after the result. Context is part of the result. A treatment target answers a different question. Once a person has diabetes, what range offers the best balance between preventing long-term damage and avoiding immediate harm? That distinction is not academic. It can change how you react to the number in front of you. Imagine a 67-year-old woman who is active, lives independently, has no history of severe low blood sugar, and is expected to benefit from years of tighter control. Her care team may reasonably aim near the healthier end of the range. Now imagine a 79-year-old man with chronic kidney disease, heart disease, irregular meals, and 2 recent falls. Pushing him toward the same target may require more medication and may sharply increase his risk of hypoglycemia. For him, a slightly higher target may not represent failure. It may represent better medicine. Then imagine an 86-year-old woman with significant dementia whose daughter organizes every dose. The most important goal may no longer be achieving a textbook A1C. It may be keeping her comfortable, preventing dehydration and symptomatic high glucose, and avoiding a low that could cause confusion, a seizure, or a fall. Same disease, 3 different lives, 3 different risk calculations. This is why the phrase, the best blood sugar after 60, is incomplete unless you ask one more question. Best for whom? And now we come to the reading that fools more people than almost any other. The fasting number. Fasting glucose is usually checked after at least 8 hours without calories, often first thing in the morning. For many adults with diabetes, 80 to 130 is a common target. But that does not make every reading outside that range an emergency, and it does not mean that every older adult should be pushed into it. A fasting reading is affected by more than what you ate the night before. Hormones released before waking can raise glucose. Poor sleep, infection, pain, emotional stress, steroid medicines, missed medication, and changes in kidney function can alter it. Even the timing of the test matters. One isolated reading is a clue. A repeated pattern is information. If your fasting number is higher than your target on one morning, the useful response is not panic. Record it and look for context. Was dinner later than usual? Were you sick? Did you sleep poorly? Was a medication missed? If the pattern repeats, that is when your clinician has something meaningful to work with. The same rule applies after meals. For many adults with diabetes, a common goal is to stay below about 180 milligrams per deciliter, 1 to 2 hours after the beginning of a meal. But again, that is a general target, not a verdict on your character. The size and type of meal, medication, timing, activity, stress, illness, and even how quickly the stomach empties can change the result. The important question is not, was I perfect after lunch? It is, what pattern keeps appearing, and is that pattern outside the target my care team selected for me? That shift from judging one number to interpreting a pattern is one of the most useful changes any person with diabetes can make. Now let us talk about bedtime, because this is where a number that looks impressively low may actually deserve more attention. Many people assume lower is always better. But if an older adult goes to bed near the low end of the range after taking insulin, or another medicine capable of causing hypoglycemia, glucose may continue falling during sleep. The person may not feel the early warning signs. They may wake confused, drenched in sweat, unusually weak. Or they may not wake until the low has become severe. That is why bedtime targets are often wider than fasting targets. A healthy, independent older adult may have a bedtime range extending to around 180. Someone with more medical complexity may also have an upper target around 180 but a higher lower boundary. A frail adult may have a bedtime range extending toward 200 when the clinical priority is preventing lows and avoiding symptomatic highs. The number is not being allowed to get worse. The plan is being adjusted to the risk that matters most. And that brings us to A1C, the number many people treat like a final grade. A1C estimates average glucose over roughly the previous 2 to 3 months. It is useful because it shows the broader direction rather than one moment. For many adults with diabetes, an A1C of 7% or less is a common goal. But for older adults, the right target can be below 7.5, below 8, or in some cases not the main measure at all. Here is the trap. An average can look good, while the daily pattern is dangerous. Suppose one person spends part of the day very high and part of the night very low. Those extremes can mathematically average into an A1C that appears respectable. The report looks calm. The body is living through a roller coaster. A1C can also be less reliable when conditions alter red blood cells or hemoglobin. Recent blood loss, transfusion, iron deficiency anemia, dialysis, kidney failure, certain hemoglobin variants, and some other conditions can produce results that do not match the person's actual glucose pattern. So if your A1C looks excellent, but your meter or continuous monitor tells a completely different story, do not assume the device is automatically wrong. That mismatch is itself worth discussing with your care team. Now we reach the number I promised, the one that can reveal what a 1C hides. It is called time and range. A continuous glucose monitor, or CGM, measures glucose throughout the day and night. Instead of showing only a single reading, it shows how long glucose remains within a selected range, how much time it spends above that range, and most importantly for many older adults, how much time it spends below it. For many people, the standard target range used in CGM reports is 70 to 180 milligrams per deciliter. Healthy older adults may aim to spend at least about 70% of the day in that range when this can be achieved safely. For older adults with complex or intermediate health, a goal of at least about 50%, roughly 12 hours per day, may be more appropriate, while keeping time below 70 to less than 1% of the day, or about 15 minutes. Do not miss what that means. The goal is not simply to create a beautiful average. The goal is to reduce the amount of time the brain and body are exposed to dangerous lows. A person can have an A1C that looks controlled and still spend 40 minutes every night below 70. A standard lab result may not reveal that. A CGM can. It can show the drop at 3:14 in the morning. It can show whether glucose falls after a long walk. It can show whether lunch causes a short spike or a prolonged climb. It turns scattered photographs into a moving picture. Current diabetes standards recommend CGM for older adults with type 1 diabetes and for older adults with type 2 diabetes who use insulin because it can improve glucose management and reduce hypoglycemia. Whether it is practical depends on cost, coverage, dexterity, vision, comfort with technology, and whether the person or a caregiver can respond to the information. A CGM is not magic. Sensors can lag behind blood glucose, alarms can become overwhelming, and readings sometimes need confirmation when symptoms do not match. But for the right person, it can uncover risks that fingerstick testing misses. Now let us address the low end clearly, because this is where minutes matter. Blood glucose below 70 milligrams per deciliter is considered low and should prompt action according to the person's treatment plan. A level below 54 is considered clinically significant and more dangerous. Symptoms can include shaking, sweating, hunger, dizziness, a fast heartbeat, weakness, irritability, blurred vision, or confusion. But some older adults, especially those with long-standing diabetes, repeated lows, cognitive problems, kidney disease, or autonomic nerve damage, may have fewer warning symptoms. That condition is often called impaired awareness of hypoglycemia. It is not simply a normal part of turning 60, but the risk can become more important with age and medical complexity. If a person is awake, alert, and able to swallow, the widely used 15-15 approach is to take about 15 grams of fast-acting carbohydrate, wait 15 minutes, and recheck. Examples can include glucose tablets according to the label, half a cup of juice or regular soda, or 1 tablespoon of sugar or honey. If glucose remains low, the treatment is repeated according to the person's plan. But this next point is crucial. Never force food or liquid into the mouth of someone who is unconscious, having a seizure, unable to swallow safely, or too confused to cooperate. Severe hypoglycemia is an emergency. Glucagon should be used if it is available and someone knows how to give it, and emergency services should be contacted. Every person at meaningful risk of severe lows should ask whether glucagon belongs in the home, where it should be stored, and who needs to know how to use it. And if confusion, weakness, speech difficulty, or loss of coordination appears but the glucose reading is not low, or symptoms continue after glucose improves, do not assume diabetes explains everything. Stroke and other emergencies can look similar and require urgent medical evaluation. So why do lows become such a major concern in later life? Part of the answer is medication. Insulin can cause hypoglycemia. Sulfonylureas and some other insulin-releasing medicines can also cause lows. Other diabetes medications have much lower hypoglycemia risk when used alone. That is why saying diabetes pills cause lows is too broad. The exact medication matters. Kidney function matters too. The kidneys help clear insulin and several medicines from the body. When kidney function declines, the effect of some treatments can last longer or become harder to predict. A dose that was once appropriate may need reassessment after illness, weight loss, reduced appetite, or a change in kidney function. Then there is routine. An older adult may take the usual dose and then eat less because of nausea, dental problems, depression, difficulty shopping, or simply forgetting the meal. Another person may suddenly become more active while gardening or walking. Someone else may lose weight without having their doses reviewed. The medication remains fixed while the life around it changes. That mismatch is where many preventable lows begin. Cognition and dexterity matter as well. Is the person taking the correct dose? Can they read the pen or syringe? Are they accidentally taking a morning medicine twice? Can they tell the difference between two similar bottles? Can they respond appropriately to a CGM alarm? These are not minor details. In older adult diabetes care, the safest plan is not necessarily the most aggressive or technologically advanced plan. It is the plan the person can carry out correctly every day. Sometimes improving diabetes care means adding treatment. Sometimes it means simplifying treatment, reducing the dose of a high-risk medicine, or removing a medication whose harms now outweigh its benefits. Those decisions belong with the prescribing clinician, but repeated lows are a clear signal that the plan needs review, not evidence that the patient has failed. High glucose still matters. Avoiding hypoglycemia does not mean ignoring persistent high readings. Repeated hypoglycemia can cause thirst, frequent urination, blurred vision, fatigue, dehydration, infections, and in severe cases a medical crisis. Over time, high glucose contributes to damage involving the eyes, kidneys, nerves, heart, and blood vessels. The goal is balance, low enough to reduce symptoms and long-term complications, but not so aggressively low that treatment creates immediate danger. This is why a single viral chart cannot safely manage your diabetes. A chart does not know whether you live alone. It does not know whether you fell last month. It does not know your estimated kidney filtration rate, whether you use insulin, whether you miss meals, whether your memory has changed, or whether your A1C is distorted by anemia. Your target should know those things. So before your next appointment, bring 4 pieces of information. First, bring the actual glucose record, your meter, written log, app, or CGM report. Memory tends to preserve the most dramatic numbers and forget the ordinary pattern. The data tells the truth more reliably. Second, write down every low below 70, including what time it happened, what you had eaten, what medication you had taken, and what activity came before it. Even mild lows matter when they repeat. Third, bring a complete medication list, including doses, timing, over-the-counter products, and recent changes. A medication review is especially important after a hospital stay, kidney function change, weight loss, or reduced appetite. Fourth, ask one direct question. Given my overall health and risk of low blood sugar, what are my personal A1C, fasting, after meal, bedtime, and CGM targets? Do not settle for your sugar looks okay. Ask for the actual ranges and what action to take when a reading is outside them. You can also ask, which of my medicines can cause low blood sugar? What should I do if I cannot eat? Should I have glucagon at home? Would a CGM help me? And if you care for a parent, is this plan simple enough for them to follow safely? Those questions turn a generic appointment into a personalized safety plan. Daily habits matter, but they need the same nuance. Regular meal timing can reduce unexpected swings for people using medicines tied to food. Hydration matters because illness and high glucose can increase fluid loss. Physical activity can improve insulin sensitivity, strength, balance, and cardiovascular health, but medication users may need guidance about checking glucose around unusual or prolonged exercise. Nutrition should not become a starvation contest. In later life, preserving muscle, strength, and adequate protein can be as important as weight loss. Unintentional weight loss, weakness, or reduced appetite deserves medical attention rather than praise. Sleep, pain, stress, infection, and steroid treatment can all raise glucose. A sudden change in readings may reflect a change in health, not a sudden collapse in willpower. And never change insulin or prescription medications solely because a video gave you a target. Use the numbers in this video to understand the conversation, not to replace it. Let us return to the two readings from the beginning. A glucose of 92 may be perfectly safe for a healthy older adult before breakfast. But if it appears at bedtime in a frail insulin user, whose glucose is falling rapidly, it may deserve attention. A glucose of 148 may be above one person's fasting target, but it may fall inside the intentional range for someone with complex health and a serious history of hypoglycemia. The number has meaning only when you know the timing, trend, medication, symptoms, and personal target. That is the real answer. The best blood sugar after 60 is not the lowest number you can force onto the meter. It is the safest sustainable range that protects you from long-term complications without exposing you to preventable lows, falls, confusion, or treatment burden. For some people, that means an A1C below 7 to 7.5%. For others, below 8% is safer. For the most medically vulnerable, A1C may no longer be the main goal at all, and the number that may reveal the truth better than an average is time in range, especially the amount of time spent below 70. So do not compare your target with your neighbors. Do not assume a higher personalized goal means your doctor has stopped caring. And do not treat a general online chart as if it knows your medical history. Take your real data to your clinician. Ask for your 5 personal targets. Ask which medicines can cause lows. Build an emergency plan before you need it. Because after 60, good diabetes care is not about winning a contest for the smallest number. It is about protecting your vision, kidneys, nerves, heart, brain, independence, and quality of life at the same time. If this clarified a number that has confused you or someone you care for, share this video with them. And in the comments, tell us which number you find most difficult to understand. Fasting glucose, after meal glucose, bedtime glucose, A1C, or time in range. Subscribe for more clear, evidence-based health explanations designed to help you ask better questions and make safer decisions with your medical team.